This is She's on Call, a weekly show hosted by ENT specialist Dr. Sujana Chandrasekhar and General Surgeon Dr. Marina Kurian. They'll be joined by guest experts to discuss an array of newsworthy medical and health issues. You're invited to ask the doctors anything. The physicians and their guests' views are their own and do not represent any institution. Please contact your doctor for any personal questions. Please hit share and join us live on Facebook, Twitter, and YouTube at She's on Call, hashtag She's on Call. Please welcome our hosts.
Hello. Hi, Marina. I'm Dr. Sujana Chandrasekhar. I'm an ear, nose, and throat surgeon in New York City and in Wayne, New Jersey.
And I'm a general surgeon, also do minimally invasive surgery, weight loss surgery in New York City. And we're so excited about this show because while you saw the show card that we had for last time we were on, which was back to school, this time we're going to talk about all the maladies you guys have from being back to work and all the craziness of the fall, which means heartburn, reflux. What can you do? And we have two wonderful guests to talk about that with us.
That's right. We have all the way from California, a very early good morning to Dr. Caitlin Houghton, who is at USC Keck School of Medicine.
And we have Dr. Jonathan Cohen, who is a dear friend, excellent advanced gastroenterologist, and he is a clinical professor of medicine and gastroenterology at NYU Grossman School of Medicine here in New York City.
So we're looking forward to having them on. Please like and share and tag your friends, anyone who's had heartburn or reflux or indigestion or belly issues, which I think describes the entire world. Please have them join us. Please let us know where you're watching from and send in a question or two and we'll ask our wonderful guests to answer them. We are live on Facebook, YouTube, Twitter, and Sri Srinivasan's LinkedIn page. We're live on scroll.in, and we are carried on WBAI 99.5 FM and WBAI.org on Mondays from 2 to 3 p.m. And we finally made our show into a podcast, Marina.
Mm-hmm. Yep. Apple Podcasts. You just have to do hashtag She's on Call, and you can find us. So we're excited about that. And but first, you guys know, you who are loyal viewers, we really appreciate that, that we're going to talk a little bit about the news of the week. And unfortunately, topic is still COVID.
Yes, the topic is COVID. I just do want to take a little detour and say, you know, of course, we commemorated the 20th anniversary of the awful September 11th, 2001 events yesterday. I can't believe it's been 20 years. I feel like we keep aging a lifetime every few weeks nowadays. But I want to send our love and our admiration, gratitude, and sympathies to those who survived, those who didn't survive, those who lost loved ones, and those who worked so hard to rebuild our nation's psyche and our cities after 9/11.
Right. It was such a dreadful time for all of us here, but really all around the country and the world. And it was such a shock. And the loss, you know, you watched some of the ceremonies yesterday, I'm sure. I mean, and you could hear from the families that this is not something you get over. And the loss is so real. And while the buildings were buildings, the lives that were lost were just so important to so many. And it's a good point. Thank you for bringing that up.
Yeah. You know, it's interesting, just one last bit. Paul Simon sang Sounds of Silence, and I remember how absolutely silent New York was after that. Do you?
Yeah, it was, so many things about that time. So many things about racing to the hospital to make sure we could help the wounded, and no one coming, very few people coming. You know, it was something that it's all over social media right now that we're talking about.
Yeah, so let's get to the next horrible thing.
It is so horrible. Okay, so, there are mandates for the COVID vaccine, and did you hear that there was one hospital in New York State that has to shut down their OB ward temporarily because 30 people, 30 nurses and other staff quit because they would not go ahead with the mandate, right? So, but as much as there's a mandate, there's also talk about the booster vaccine, and we have a great image for that about why it is we should get a booster. And it's sort of similar to why is it if I had COVID-19, why do I need to even get the vaccine? But it's a great image that we can pop up, which shows the what our immune system does from when we got the vaccine to when we then get the booster. Hopefully that's coming up soon. If not, I can say that there's a primary response, right, which shows that your antibodies will shoot up. And then when you get the booster, the secondary immune response really shoots up your antibodies even higher.
Right, higher and faster. So this is really important. So the first two arrows are your first shot and your second shot of the mRNA vaccines. And then you have this nice, robust primary immune response, but we are hearing about breakthrough or spillover infections. When you get your booster, you get this much faster, much higher secondary immune response that we think will last longer. So it will be more protective. And this is really important when we're confronting variants like the Delta variant and upcoming variants that actually spread more readily from person to person and are more severe when they infect somebody. So Israel has mandated boosters at 6 months. In the United States, we're talking about 8 months. We're learning as we go along, but right now, 8 months if you have an underlying medical condition. So if you've been vaccinated 8 months ago and you have an underlying immunocompromised condition, please seek a booster or talk to your physician about it. We have people watching from all over. Thank you, Irma Chavez, who's watching from Maryland. Thank you, Tim Stone, who's watching from Pennsylvania. Thank you, Miriam Berkeley, who is looking forward to her booster and is asking, apparently she got Moderna vaccines. Should she get a Moderna booster rather than a Pfizer booster? I think the answer to that is yes, she should get a Moderna booster. Is that right, Marina?
Yeah, I think so. And I think that's what they're recommending, although there have been a few studies looking at mixing and matching. But currently their Moderna booster is up in front of the FDA. And also, isn't it Moderna that came out with a triple, like it covering COVID, the flu, and I can't remember the third thing, but we'll figure it out by the end of the show. I'll update you guys.
We'll figure it out. But I'm glad you mentioned that, because the American Academy of Pediatrics and other groups have said that you can get the COVID vaccine and the flu vaccine at the same visit to your doctor, or to your pharmacy. So you can actually get both vaccines at once, which is, I think, very helpful to streamline the process of staying well and away from COVID and from flu this season as we open up. We have some really good data that came out based on an article in the New England Journal of Medicine looking at why you should get a vaccine. And I think particularly, Marina, as you mentioned, those healthcare workers, let's look at these slides and compare COVID risks, whether you're vaccinated or not vaccinated. And this came out in the New England Journal of Medicine just a couple of weeks ago, looking at 2.6 million people. So this is not like a small little study, right?
Right. So let's look at the next slide, which talks about, is there a risk of kidney injury? There is, but the risk with COVID infection is more than 14 times than actually having it with the vaccine. The Pfizer vaccine actually reduced the risk and found that the study found that it was protective against getting kidney injury. And so the next slide.
So, people talk about myocarditis or abnormal heart rhythm, and the vaccination was protective more than 3 times of getting abnormal heart rhythm compared to not being vaccinated.
Right. And so the next slide shows us what about stroke, because we've heard of all these what we call thromboembolic, but basically these clots that were forming either in the leg and the lungs, but unfortunately also stroke. And it was greater if you got COVID, it was much worse than if you actually had the vaccine. So the vaccine was protective, looking at 2.6 million people. So next slide is talking about brain bleeds. That's what intracranial hemorrhage is. And again, if you had the vaccine, you were protected because the infection was 6 times more likely to cause this than the vaccination would be. And we'll do the next heart attack.
So COVID infection increases your risk of heart attack 4 times your normal risk. Vaccination made no change in your risk. So that's a remarkable reduction in your risk if you get vaccinated versus if you get the infection and you have not been vaccinated.
And then we're talking about embolism. So this is blood clots in the lungs, and vaccination reduced that risk to half. But if you got COVID infection, it would have increased it more than 12 times. So next slide, let's do the next one before we run out of myocarditis. This is the one you were talking about, which is an inflammation of the heart muscle. And we saw that one of the vaccines was causing myocarditis in young males predominantly. But it was a small number. And in essence, if you had the vaccine, it was better.
Right. So 18 times or something risk of getting myocarditis if you got COVID versus 3 times if you got the vaccine. But it is much safer to be vaccinated. And frankly, as healthcare professionals, it is much safer for our patients if we are vaccinated.
Okay, so now we're going to talk and meet our guests. We're so excited to have them again. Caitlin Houghton, who is a robotic foregut surgeon at Keck Medical School in LA. She's an assistant professor there. And Jonathan Cohen, who's a clinical professor of gastroenterology and medicine at NYU Langone and NYU Grossman School of Medicine. We're so excited to have you guys join us. We're going to be talking about heartburn, reflux, and what we can do. We're so excited, really. I'm really excited because I got to put the show together, so I put my friends in.
Yes, hello, thank you.
Welcome. And as an ear, nose, and throat surgeon, so I really just care about the mouth and the upper part of the swallowing apparatus. So I'm like the tag team runner that hands off to the 3 of you guys.
No,
So
you know what? The ENTs are constantly telling my patients, "Hey, my ENT doctor said I have reflux." I'm like, "Oh, did he or she? Huh? Okay." and then we're sending them to John, right, John?
Well, the mouth is just the gateway to the GI tract.
That's all we do. So let's talk a little bit about heartburn and reflux. I think if you ever watch TV and you don't skip through the commercials, all you hear is commercials for heartburn and reflux. So John, can you tell us what exactly it is and what symptoms we should be looking out for?
Sure. I think the commercials give you heartburn. It's an interesting thing. There's classic symptoms of a burning sensation in the chest, something that happens after meals and maybe rise up to the throat. People will describe that. But, I think that's, the classic. But many people have a variety of other symptoms that are actually reflect reflux, which is flowing backwards of gastric contents, which would be acid and occasionally regurgitation. Such a common, I think it's 10 to 20% of the U.S. population has some degree of reflux, and about 5% have it about twice a week, which is, can be, besides being disconcerting, can actually, lead to some complications as well.
So this is just a image kind of giving everybody the idea, like, right, our esophagus is our swallowing tube and it goes to the stomach. And then there's supposed to be this, it's not like lower esophageal sphincter, it's a higher pressure zone that prevents reflux of contents. And sometimes for a variety of reasons, there is reflux of whatever you had up into your esophagus, and that's what's giving us the heartburn and reflux. So of those symptoms, John, I mean, some things are very common, right? If we go back to the symptom slide, right here. So this is stuff that most people will talk about heartburn, or they feel stuff coming up. And it's funny because if you've never experienced heartburn, you don't know you have it, right? Because you know what I'm saying? Like, you have something, but you don't know what to put a name to it. You've had it for so long, and someone's like, well, I get this heartburn. And they're like, wait, I get that too. Do you know what I'm saying? It's like,
yeah, and the converse is true too. Some people will come by and say they have a diagnosis, and what they're really talking about is burning way down in their stomach, or feeling full, some other things that are very relevant for someone to work up and figure out, but they're not exactly the same thing. So people use terms lightly. So, people will usually volunteer a variety of symptoms, but you're right. I think there needs to be more awareness of what reflux might be, and especially some of the other symptoms, such as atypical chest pain. So sometimes the acid can go and trigger a response that feels much like one's having a heart attack, and sometimes someone might do that and may have a slightly abnormal EKG and need to have a cardiac evaluation. So there are a variety of symptoms that could that are different from the classic burning sensation in the chest.
Since so many people, like, now that they had over-the-counter medications, right, like Pepcid and Prilosec and all those things, are, all the commercials that we see. When is it that it's really pathologic and you need to see a gastroenterologist and not just treat yourself? I don't know what the stock in Tums is right now, but I'm sure it's high.
Well, first of all, everyone should see a gastroenterologist. No, this way walking down the street. No, I think that we talk about refractory symptoms. Symptoms if you're taking something for a while and you have symptoms that just don't get better. We look at alarm. The concept is of alarm symptoms. Things that if I see my GP and I tell them I'm having this more than twice a week, or it's waking me up at night. Nocturnal symptoms are important. Family history. If someone in my family had upper GI cancer, esophageal cancer, stomach cancer, I think in the family that would heighten my concern about maybe I should ask more about it. But taking a pill, over-the-counter pill, for 2 days and still having symptoms doesn't mean that something terrible bad is going on. It may take a little bit longer for some of those medicines to work. But generally speaking, other things like food getting stuck, problems swallowing, if you're having any signs of bleeding, you're feeling weak, you're losing your appetite, weight loss. So there's a lot of other things that are in addition to that really should perk your ears up and get you in to see your physician.
I appreciate it. I think you talked about how maybe you come in with something that sounds like heartburn and you end up with an EKG and you're actually having a cardiac event. I know, Caitlin, Dr. Houghton, we actually have seen the opposite for women, where they come in and their cardiac symptom is actually mistaken for heartburn or for some GI thing. So can you talk to us about how we distinguish it? When should we know to go to the ER, for example?
Hi. Yeah, I think that when we're, if you're having persistent chest pain that's intermittent, even if it's kind of comes and goes throughout the day, or if it's getting worse over time, then you probably need to come to the emergency room. As far as the symptoms go, because cardiac symptoms for women don't have that classic radiate to the left shoulder, some of those signs, and it tends to be isolated in the chest. That can be confused for acid reflux or a cardiac event. So anytime you're having chest pain that's increasing or getting worse, coming to the ER is a good idea.
We just had a question from India right on that. So thank you very much.
What I was going to say is this is just so great because, as we kind of mentioned, we actually are like a team that works together, right? We work so closely with the gastroenterologist. we get mad at the ENT surgeon. No, I'm just kidding.
Whoa, what I do? What I do?
Let's talk a little bit about how do we kind of diagnose somebody if they're having really true reflux that can become a problem. So let's just talk a little bit about endoscopy, Jonathan.
Okay, well, let me back up a bit and then say that some degree of reflux is normal. So 4% of the time, acid does get into the esophagus, and that's what's normal. We have all these mechanisms to clear it. We have saliva. We drink some water and wash it down. We have some, some barriers, like you can talk about a little bit about the diaphragm to help prevent more acid coming up. So, but to diagnose it, some people will try one of those medicines you talked about that you see on the evening news. You might try that for a period of time and see if you get relief. But that doesn't always, 100% diagnose whether you do or don't have reflux. If you had something from the stomach, say like an ulcer, you might also get better from taking a acid-reducing medicine. So endoscopy is a way to go look with a camera, actually, for damage, physical damage in the esophagus that you can see with your eyes, or sometimes that you can actually pick up on a biopsy. You can also see some other inflammation. For example, for this entity, eosinophilic esophagitis, which is something of an inflammation that may be related to some allergies. So that may be related to acid, but also certain foods. So you can use that to diagnose. You can see the classic definitive study is a pH study, where you can put a tube in through the nose, usually while you're awake. It's not very pleasant, but you go and put that in there, and you can measure over 24 hours how much acid is going in, and keep a little diaries when you have symptoms, is to see whether it correlates. There are also clips that you can put internally and measure that remotely and without having to have the tube through your nose for a day. So there's different ways to measure there. You can also look at the pressure of that sphincter zone that you showed in the slide and see whether or not there is an adequate sphincter. And you're showing a slide now, there is a hiatal hernia, a little bit of a gap that decreases the normal mechanical barrier that the diaphragm, the muscle the diaphragm poses, that will sort of lock in anything as a valve, if you will, acid from coming back. And if you don't have that, it gives acid sort of a head start into rising up and irritating the esophagus.
So, I think we say, oh, that's bad. But maybe, Caitlin, you could explain to us why it's bad. Why is it bad that the acid that's in our stomach gets up just, a little bit up into the esophagus? What is esophagitis? What can happen if you have that happening more than that small amount that John said happens normally?
Yeah, so acid reflux, the esophagus really isn't made to be seeing acid. So the lining, or the cells that line the esophagus, are not used to seeing acid. So when they do, it tends to kind of break down that mucosal lining, cause ulcers or inflammation in that area, which not only can be painful, but it can also lead to some scarring, which you could get like strictures or narrowing of the esophagus. And in that case, patients usually feel that they, can't swallow very well. They have food kind of feels like it gets hung up a little bit. So often we can see that. That's called a peptic stricture. We could also see changes the mucosa or the lining of the esophagus, where it's trying to protect itself. And so it can turn into a cell called Barrett's. This picture that you're seeing is of the erosion or the esophagitis, those irritation. And then the next step is Barrett's esophagus. And when you get here, the esophagus is trying to protect itself. So it's changing the cell type to actually look more like gastric cells, it can easily handle the acid in the esophagus. But that's dangerous, because once it does that, the body's not really good at doing that. So then it can progress, or those cells can become disorganized and become cancer. So actually, a really severe acid reflux is one of the main precursors to esophageal cancer. And I don't think many people know that, actually, that untreated esophagitis is very dangerous and can lead to cancer in some cases.
You know, I want to just chime in there. I think it's really important for viewers and listeners to think about it. It's not a one-to-one saying, well, I have reflux all the time, but it's very mild. And so if I go and do endoscopy and look at, 10 people with reflux and someone has severe symptoms, sometimes I'll see it looks pretty normal. And other people who have relatively milder symptoms can have more severe reflux or actually have already Barrett's, which is a sign perhaps of having over 5 years of having low-level acid exposure. And so duration of symptoms is important. And I think that esophageal cancer, fortunately, is still much rarer than other kinds of cancer, but it's still growing, and perhaps with increasing in our changes in our diet, increases in obesity, various things. So I think that one should be aware that it's not just the degree of symptoms and how bad they are with what you're going to find. So if you have alarm symptoms, you ought to have a look.
Right. So we have a slide on some of the stats that was put out, I think, by the ACG. And it talks about how 30% of patients still have chronic GERD symptoms or heartburn reflux, right? Despite taking medications like a proton pump inhibitor, which is like omeprazole, Prilosec over the counter. Can we talk a little bit about this slide? Caitlin, what are your thoughts here?
Yeah, I think that, acid reflux is so prevalent in our community. You see, you go to the airport, for example, and they're selling Pepcid or Tums, and so many people go around kind of self-treating their acid reflux, thinking it's so common, so it must not be, that big a deal. And I think the biggest thing, is that if you're having persistent reflux and you're taking those medications, whether they're over-counter or prescribed by your doctor, to have a professional following that for you. It's like any other disease process or any other medical condition. It really needs some expert eyes to be making sure that which category you fit in. Are you mild, like are your symptoms high, but you have no injury? Then that's good. You might be able to stay on your medication. But if a medical professional can then kind of work you up with the endoscopy and things like that, you may be having more issues than you even think because your symptoms aren't as severe as as the actual injury is to the esophagus.
Chiming in as the ENT person here, I'll tell you that when that acid comes up and it's severe enough, it can track all the way up, and we actually see it as hoarseness that persists, as trouble swallowing, where you feel that stricture or that constriction up in your neck as opposed to in the middle of your chest. And we can examine you in the office and say, hey, the back of your larynx or your voice box looks really red and inflamed. And this is very typical of what we see with reflux, with heartburn. And we will actually say, please go see your friendly gastroenterologist, because you really want to make sure that you're not setting yourself up for, as our guests have said, Barrett's esophagitis and essentially a precancerous lesion. We have people watching from everywhere. I'm so glad Ellen Austin remembered that we were on today. She said she almost missed it. So Ellen and our viewers, because the world is opening up a bit, we are going from every week to the second and fourth Sunday of every month. So please do join us then. We have Project Amis says that they had serious esophageal spasms a while ago from food poisoning and thought they were dying. And, I think that those esophageal spasms can really be horrible. So Caitlin, can you talk to us about what people should do to avoid those and what is done in the ER to treat those?
Sure. Yeah. Esophageal spasm is just basically the esophagus is contracting really hard. And so that feels like chest pain. And sometimes that's because of ongoing inflammation. Sometimes I think our patient was saying it was an acute event when they were sick. But that feels like a squeezing pain, which is why it sometimes gets confused as a cardiac issue. But I think if you're having that, the best thing is to breathe through it, seek medical attention. You know, there's not a lot at home you can do. It's kind of going to have to take its course and break on its own. There are things like, well, peppermint oil, like Altoids. I don't recommend that you just do that and, you know, call it a day. But things that can reduce the contraction of the smooth muscle in the esophagus. Altoids is a great little trick. And we use that to treat some patients that have a disorder of high pressure zones in their esophagus.
I want to put up another slide that we had on like side effects, because it's one thing to talk about how taking the medication in the short term, as you said, it's in the airports, it's in the supermarkets, in the drugstores, but there are issues with taking medications long term, and you know, so for those of us who prescribe, our electronic medical records always like, well, this drug might be increased in the presence of having, you know, being on the proton pump inhibitor or whatever. So those are some issues. And also, while there are common symptoms that we're talking about, Jonathan, you can talk a little bit about how people are being seen for some other reason, get an endoscopy, and they're found to have bad esophagitis that's actually silent. Like, they have no idea that they have this reflux. They just don't feel it like everyone else does.
Yeah, I think that you know, they don't have that early warning system that may be helpful. You know, I think that in general, even though the issue of side effects comes up all the time in the office. People are always worried about it. A lot of people want to get, rightly so, want to get on less medicine. A lot of people have been inflamed by, you know, alarm in the press, which has not always had the best epidemiological support for various effects of the medicine. But in general, if you have erosive esophagitis with those ulcers that we saw in the earlier slide and diagram, or a big hiatal hernia, or certainly Barrett's, we feel that you're most likely going to need to be continually on the medicine and have to have your doctors take into account the risk of side effects. For example, the concern about bone fracture, osteoporosis, and maximizing your bone health, weight-bearing exercise, bone density, following your vitamin D, etc. If you don't have Barrett's when you have an evaluation, you don't have erosive esophagitis, it's predictive that you're perhaps going to be able to get off medicine. You know, there's a big thing about the sensitive esophagus. And it's kind of curious about the role of stress. You know, I find stress doesn't cause it, but it makes every symptom worse. It may make people eat worse, and then cause dietary-related increases in symptoms. But, you know, people respond differently. And if you don't have symptoms, but you have some dangerous findings, then you're going to have to either find a better balance where you can confirm that you're not doing ongoing damage on a certain level of medicine. So sometimes I will lower the medicine to a point, and I might even in those cases have another look just to make sure we're not fooling ourselves and letting them have ongoing inflammation, which we think, as Caitlin mentioned, could lead to strictures or even, you know, even Barrett's. Although most people, when you don't have Barrett's once as an adult and they've had reflux a long time, they don't tend to go on and get Barrett's, you know, subsequently.
So that's actually really good news. But you did mention diet, right? It's not medicine or nothing. And I think we are learning more and more about the interaction of diet and all sorts of health issues. So a low acid diet is something that is advocated for heartburn and reflux, and that can be actually quite tasty. There's some good cookbooks out there for low acid diet, but can you explain to us what that really entails, Caitlin? Like, can they never eat another tomato?
Mm-hmm. Yeah, it's hard. You know, the diet is pretty strict. And no, everyone has little different triggers, but yeah, basically staying away from acidic foods like tomato sauce, and sometimes it's coffee and chocolate and fatty foods. So it's actually really everything good for you, or good tasting, not good for you. But those foods that tend to like cause the stomach to increase the acid secretion. So, it's hard. I think that smaller meals, eating, healthier, cleaner diet, those things help. Losing weight can help if you're overweight. That can help reduce the intra-abdominal pressure. So sometimes that alone can do the trick. And then sometimes if you have, the issue is that sometimes diet's not going to be enough for everyone. Some patients have an anatomical defect or a hiatal hernia or their valve is blown out. And in that case, you could change your diet all you want. You can take all the medications you want, and it's not going to get better without addressing the anatomical or the barrier, which is defective. And that's when surgery comes in, which is maybe some people are wondering why I'm on this podcast.
So we're going to talk about surgery. We have a slide on medical versus surgical therapy that we're going to pop up. And then we definitely want to talk about hiatal hernia as well. So the slide's showing that surgery in a randomized controlled trial, which is our, what we say is really the holy grail of great research, that there was better quality of life and improvement in the GERD scores at 1 year in patients who had anti-reflux surgery or fundoplication, which we're going to get into, versus patients who got a proton pump inhibitor and maybe an antispasm medication, and those who just got the omeprazole. So 67% versus 28%. John, what do you think of this study? It's small numbers, but it still was done with very stringent clinical guidelines.
Right. Well, my understanding of the rest of the literature and my experience the last 25 years is that the people who do the best with anti-reflux surgery or some of the newer anti-reflux endoscopic procedures are the ones who do respond very well to once a day or even twice a day proton pump inhibitor, acid suppression medicine, and lifestyle. They just can't. They don't want to be on it for the rest of their life, and they're young, and they do the best long term. This idea of the refractory. There's two subsets of the refractory: those who really do require a mechanical fix, as Caitlin was talking about, and those who don't really have, pathological reflux. That whatever reflux is there is not causing their symptom and pain, and that's a big red flag. So I think that's a hard one that goes in Caitlin's lap all the time. I don't know, Caitlin, how do you deal with that dilemma?
Yeah, I think it's hard because the symptoms of acid reflux are so broad. So it can be chest pain or feeling a burning in your chest or hoarseness or a cough even. And so a lot of those patients, sometimes we get patients that are refractory, or meaning that they've had long-term acid reflux. They're not having a lot of luck on the medications, and maybe they've been misdiagnosed. And so it's really important that we tease those patients out, like you said earlier, by doing a complete workup to make sure that it's not just, oh, you have these symptoms, we're going to give you the medication, but that you get an endoscopy to see whether you're having changes, that a pH test or a little probe that goes in your esophagus and measures the amount of reflux, that can give us an idea, oh, this is really from acid reflux or not. And then if it's not looking like it's acid reflux, what else could it be? And kind of doing further testing to kind of try and figure out what it could be. So there are a small subset of patients that possibly have been misdiagnosed, and that's why they're refractory. So it's important that between your GI doctor and the surgeon and your ENTs, and that we all kind of figure out why you're having the problem before it's treated.
This is a really popular topic. We have so many questions coming in, and our guests have been answering them even before the questions are posed. So I want to thank you so much. Once you've made the diagnosis of a hiatal hernia, Caitlin, what do you do? Is it a operation with a big incision? Is it a big? Tell us, what is a hiatal hernia? What do you do for it, and what are the latest techniques to do it as minimally invasively as possible?
Yeah. So a hiatal hernia is basically, there's a hole in the diaphragm that's natural. That's where the esophagus should come through, and it should be just big enough for the esophagus. But a hiatal hernia as part of the stomach is pushing through that hole up into the chest. And that displaces the valve between the esophagus and stomach, which is supposed to protect you from acid reflux. So it tends to go hand in hand with symptoms of acid reflux, not always. There are 4 types, as you can see in this slide. One type, it just depends on how much stomach is above the diaphragm and how that is configured, what type it is. But if a hiatal hernia is symptomatic, it's contributing to really bad acid reflux, or you're having some other symptoms with kind of food regurgitating coming up, then it should probably be fixed. The surgery itself can be an outpatient or one night overnight stay. It's done through very small incisions, surgically. And then if you have a hiatal hernia, it's hard to do that endoscopically. But so surgically, small incisions, we can do it either laparoscopically, which is traditionally small incisions, or robotically, which is my specialty. I do a lot of robotic surgery, which I'm still doing the surgery, which that's a question patients ask. But the robot comes in, hovers over the patient, connects to these little what we call trocars, or that are kind of placeholders within the skin. And then I control the robot, but it allows me to have a wrist and really have a natural flow, really gentle in the tissues, 3D visualization that's high definition. So the robot is an advancement in technology that's really helping us to treat these patients with the most minimal tissue injury and very little pain, actually. Like I said, the surgeries usually are getting the stomach back where they need to be and then reinforcing the valve. So, yep.
Caitlin, this is, actually that picture that was just up showing the herniated stomach. This is one of my, it's kind of sick. Hopefully our viewers will excuse it, but I love seeing this because this is to me like, we're going to help, and this is like an enjoyable surgery to do, right? And you can see this is an inside picture. Hopefully no one's, throwing up their breakfast, but like they have the diaphragm and you see the stomach that's going through the hiatus. And then, this is just like a perfect situation for surgeons to intervene and try and make a difference here.
Yeah, I think that, when there is a hiatal hernia, if we can reduce that and reinforce the valve, most patients are going to feel so much better. And that's really rewarding for us as physicians to really make an impact on someone's quality of life. So it's a very satisfying surgery for us because we know our patients likely are going to do so much better.
John, what do you think about all this?
Well, I just want to temper a little of this. Everyone, the 3 surgeons on the group are really they're sharpening up their robotic arms. And Caitlin mentioned regurgitation. If actually contents are coming back up, and that is the part of the history, which is a smaller subset, that leans more towards fixing the hernia. But the vast majority of patients that I would endoscope for reflux, and those are people who've tried a little over the counters before, and they've had some other, some symptoms to warrant a look. They very commonly have a hiatal hernia of some degree and of size, and how big open the valve is a factor that we can assess endoscopically. But the vast majority of those people never need surgery. And I think it's very important for people watching this to say, oh my God, I have reflux symptoms. I'm going to need to have a hiatal hernia surgery. Most of them do not need it for that. But I think that's an important, sort of putting it in perspective.
I would say that probably Caitlin feels the same. I don't operate on every person that comes in with reflux. I do really work with our gastroenterologist, and Jonathan and I actually have a very close relationship in terms of the patients that I see and that I send to him, and who is a candidate and who's not. And we want to get into some of the endoscopic therapies as well. But first, I just want to show a picture of what we're doing when we treat reflux, and how we're using the native tissue in the stomach to try and recreate that lower esophageal sphincter. If you want to comment on that, Caitlin.
Yeah, so the valve is basically a structure between the esophagus and stomach that should close after you swallow. You take food down, it should close so that food can't rush back up and acid can't rush back up. So what we're trying to do is kind of increase that barrier to reflux by recreating a valve. And we do that by taking a part of the stomach called the fundus. It's a floppy, redundant part. It doesn't mean that you're going to not be able to eat as much, but we take that part of the stomach, we wrap it behind the esophagus and sew it to itself or to the esophagus. There's little nuances within a patient's workup to tell us whether they're going to tolerate, do we wrap it all the way around the esophagus and do a full 360-degree wrap, or do we do a partial, like a 270-degree wrap? And it kind of depends. Most patients, if they're coming for acid reflux and have their hiatal hernia repairs these days, are going to get a partial fundification, meaning we reinforce the valve, but we don't do it all the way around, so that we eliminate some side effects. So anytime you're talking about surgical intervention, you have to weigh the risk and the side effects of the procedures. These do a great job of stopping reflux, but we're reinforcing this valve that you're not used to. So some patients feel like food gets hung up for a little while. That's why we kind of do a partial so you can swallow through that well. And also if there's other side effects that people talk about, like gas bloat and feeling like gassy or full. And so while surgery is a really great option for a lot of people, we have to kind of weigh all of our options and see if are going to get better with medical treatment, whether which fundification can we do. We have to it's an art to see kind of exactly what surgery this patient needs, and we need to tailor it to each patient's experience.
I think that's absolutely correct. I think every one of us is very in tune with that personalized medicine approach. And this is a picture of a partial, or toupee, we call it, fundoplication done with the robotic instruments, right? So this is actually, I wish mine all looked like this, but this looks really fantastic. This is one I grabbed from one of the sessions. I think it was from Sage's.
So, we're live on Facebook, on YouTube, on Twitter, on Shree's LinkedIn, on scroll.in. We'll be carried on WBAI 99.5 FM and WBAI.org Monday from 2 to 3 p.m. Eastern. And we're on a podcast, which is really fun. I think we have found, Marina, that in the last 52 shows that we've done, that theme of physicians actually being physicians and thinking holistically penetrates every single thing that we think about. So no, nobody's going to jump to you to operate on you if you happen to go to the doctor with your heartburn. They're actually going to assess you. We have questions coming in about diet. I'm just going to read these because they're great, actually. We have Lorna Honda, who says that she has Schatzki's ring, and we can discuss that. We have Udatta Ganguly, who says he had an ulcer and took a long time to fix up his diet, and he's getting better, and what can he expect next? And I think we talked about that quite a bit. We talked about side effects of these proton pump inhibitors, which was one of the questions from Project Amis. Rakesh asked us about what happens, what foods should he avoid, and we talked about low acid diet and tailoring it as best as you can so that you actually follow that diet. But I think one of the points Caitlin made was to eat several small meals a day so you're not ravenous and reaching for the fried foods or the caffeine. We have Carla Baranakis saying, does gastric sleeve surgery have an effect on the risk of getting GERD? And maybe, John, we can ask you.
Yeah, well, we're going to hold on that because that is a really complicated question. And we're running out of time. And I really want to talk about some of the endoscopic options to treat GERD, because there are a couple. And there were more in the pipeline. But Jonathan, let's start talking a little bit. And I know, Caitlin, you have some experience with this too. About transoral incisionless fundoplication, which is a method to try and recreate that. My cat. Okay. anyway, to recreate that valve for us. So Jonathan, talk to us about transoral incisionless fundoplication.
Sure, I will, but I just wanted to quickly just chime in on those questions. You know, that one about this quitting smoking, and you know, there's a lot of nuances of these other additional conditions that have to be taken care of. Regarding the diet, you know, once you fix the hiatal hernia or do a fundoplication, it's not you're done because now you've done the surgical. You've got to do the lifestyle and dietary things as well so that you don't have a recurrence 10 years later. So I think that, and my emphasis in the diet is more on dealing with obesity, dealing with portion size, the timing of the evening meal, you know, certain items that may relax the sphincter pressure, like caffeine and chocolate. We haven't mentioned, and alcohol. So, you know, whether it's the tomato or having a big pasta dish with lots of greasy, oily tomato sauce that tastes great, you know, I don't know, but it's not just avoiding a couple of those foods.
Jonathan, tell us about timing. When is the last, what is your advice on timing of eating?
Well, I tell people as early as they can possibly fit into their schedule. I mean, certainly not lying down for 90 minutes. You know, people have known for thousands of years about elevating the head of the bed to give a mechanical advantage, and not lying on your right side, lying on your left side. So these are some things. But I think that also eating earlier and not eating breakfast later is good for weight loss too. So, but I want to, you know, really address Marina's question. So the some of the newer, if the hiatal hernia isn't too big, you can, with an endoscope now, without all those robotic arms in the outside, you can actually, from the endoscopic perspective, now do a lot of procedures, including suturing and full thickness plications. You can recreate some of the angle and the barrier to reflux coming up from the inside as an incisionless procedure called the TIF procedure. There's also procedures where you can go and use radio frequency, low level, low depth inflammation called a Stretta procedure to actually fibrose down and create a little bit more of a perhaps a mechanical barrier to acid coming back. They're probably in the 60-70% success rate at getting off proton pump inhibitors, as opposed to the high 90s for a fundoplication done as an outpatient. So it's a lot of this is correct patient selection. Here's a nice slide of the what that recreating the angle is using this model is actually pledging through and through full thickness sutures, and at the same time you have another scope alongside that can watch and see that you watch this being done. So this is takes about an hour and a half endoscopy procedure as an outpatient. So this is the TIF procedure. So they're out there, and there are some items. Still good patient selection, really good assessment beforehand about their gastric functioning. Do they empty well? Do they have a problem with swallowing, so that they don't have, after you create these barriers, you want to make sure that they're going to be able to efficiently swallow. So does the esophagus work properly? So all these things have to be done carefully in concert with the surgeon and the endoscopist, sort of talking and working together.
So there's a thing about Barrett's, right? That if you have Barrett's, you really have to address the acid reflux, and we have surgical literature that says, this is actually the TIF, showing a completed TIF and how it works all around. But we have surgical literature that talks about how Barrett's can be halted in progression and in some cases improved with a fundoplication, right, Caitlin? But I also want to then have you, Jonathan, the last few minutes we have, talk about what are some of the endoscopic things that can be done to treat Barrett's. So Caitlin first, and then Jonathan.
So Barrett's does need to be addressed, and it's kind of a decision to make, whether it depends on how bad the Barrett's is, whether we're going to treat the Barrett's first with endoscopic therapies like John is going to talk to you about, and then when the timing of reinforcing the barrier. Because once we treat the Barrett's, if you have ongoing injury, you could get that Barrett's back. So we want to both treat the Barrett's, disease and stop the progression or stop the acid reflux from happening any further. And that's where fundoplication can play a role. John, what about the endoscopic therapy of?
Sure. Well, there's 4 things you can do. When you have Barrett's esophagus, there's 4 things you can do. You can follow it carefully and make sure it doesn't progress. We tell people they have a 1 in 500 or to 1 in 1,000 lifetime risk of getting cancer of just plain old Barrett's. And it usually progresses, and you can follow them, in surveillance, careful biopsies using new imaging techniques to catch early changes. And then there's the 3 other ways of getting rid of it. You can freeze it, you can burn it, you can remove it. If you see a nodule where something looks a little suspicious, you can remove it, and then you can go and bring someone back. It's a series of endoscopies to make sure you can get rid of all the visible Barrett's. But something that people should know, once you do get rid of it, you still have to suppress the acid, whether it's with surgery or with ongoing medicine and lifestyle. You still have to survey, because you can, after removing the Barrett's, it can come back, and it can come back underneath the surface. So it's not a, oh, I'm done, I got rid of my Barrett's, I don't have to worry about it. Especially at the GE junction, it's very hard to get, long term, you have to follow that carefully, and you'll have to do that regardless of what option you choose to deal with it.
We had a funny comment come in from Project Amis, and he said, that robot is hella scary, but actually that robot is hella cool. Can you talk to us, Caitlin, just in the last couple of minutes that we have, about how did you learn how to go from, a hands-on to a hands-on a robot surgeon?
Yeah, I think the drive to do it was really patient-centered, because the patients can have less pain. It's gentler on the tissues. You don't have to put so much force on the tissues. Basically, small incisions, laparoscopic surgery, you're operating with chopsticks. You don't have any wristed instruments. So you really had, surgeons have adapted to very advanced doing advanced surgeries with those instruments. But the robot really takes away some of those challenges for us. It's really gentle. It gives us a wristed instrument back. We can follow the natural planes within the body a lot easier than when we're doing it laparoscopically. So it's actually, even though it does look very intrusive, it's actually really gentle, and it helps the surgeon kind of follow natural planes and suture like we would if we were doing open surgery, with the benefit of having the very small incisions. It takes some time to learn. I went through a lot of training courses, and I continue actually to be a teacher of robotics and help other surgeons who are wanting to adopt this into their practice to help them do that safely for patients.
John, you want to give us, we're actually coming close to the end of the show, and I want to thank you guys both so much. But John, do you have any takeaways for our viewers?
Yeah, 2, I guess. One is the idea that we talked about. Reflux can have many different kinds of symptoms. And so you have to be thinking broadly about that as a possibility, and that everything, if you think you have reflux, there might be other things. And so that's something, if it's persisting, to speak to your doctor. The second is what alarm symptoms are. Things where you should really be, if it's going on for 5 years, even if it's low level, if you have a family member with cancer, if you're having some anemia, if you're losing appetite, if it's happening at night, happening more than twice a week, you at least got one look to make sure you don't have a more risky situation. And just the last take home is just what you said at the very beginning. I didn't think about it, but juxtaposing this COVID and with our 20th anniversary. And so we find ourselves as physicians around here, especially here in New York, our role in restoring hope and optimism is really ever strong. So I wanted to thank you for having me on the show today too.
Caitlin, do you have some takeaways for our viewers?
Yeah, I think that, acid reflux, as it's a common disease, but it's a complex one. So the one answer for one patient isn't going to be the answer for your neighbor. And so really working with your physicians to tease out exactly what you need on a personalized basis is important. And as you've seen, there's a lot of, we've talked about endoscopic therapies and medicine and surgery, and really you've got to work with medical professionals to kind of make those decisions with you. So even though it's common, it's very complex. And yeah, I think that there's a lot of options for patients. I think some patients with acid reflux feel like they're going to have to live with this forever. They're going to be on medications forever. But seeing the right doctors to help you along and make those decisions, potentially we could change that course for you and get you on symptom-free, or at least control your symptoms.
Thank you so much, both of you. I think you shared so many words of wisdom. I'm going to go back and watch and listen because I sometimes don't focus as much as I should when we're on air. But thank you so much to Dr. Caitlin Houghton, who is robotic foregut surgeon and assistant professor of surgery at the Keck School of Medicine at the University of Southern California in Los Angeles. Dr. Jonathan Cohen, who is an advanced gastroenterologist and clinical associate professor of medicine and gastroenterology at NYU Grossman School of Medicine. We've covered from coast to coast today. Thank you so much for sharing with us.
We want to thank our team because we do have a production team that really takes care of the show and helps us present all this information to you.
And today, actually sitting in for Shri was Stefan Kaplan. So thank you so much, Stefan, for filling in today and helping us make this show work.
All right. And so a reminder that we do have podcasts and we also have moved the show to twice a month right now. And so the next show will be on the 4th Sunday of this month. Thanks so much, you guys, for joining us today.
Bye.